Good morning, everybody. I'm Claire Morgan. I'm Director of Implementation and Partnerships at NICE. Delighted that you are able to join us today for this session where we're going to talk about our new approach to prioritising guidance. Really, this is so important for us that we're beginning this conversation with you today. And in a minute, I will introduce Professor Jonathan Bendra, who will talk through our new approach and how we're considering how we really think about what matters most to the health and care system. So ultimately we get the best care to people fast and ensuring value to the taxpayer. And really today is our first opportunity to be talking to you as stakeholders in the process. So the plan for today is we will ask Jonathan in a minute to talk for about 15 minutes or so about the priorities and the proposed framework, and then we'll have lots of time for questions. So put the any questions that you have into the chat and we will be able to kind of work through those. We are planning today on having over 1,000 people join us. So please be aware we might not be able to get through all of your questions, but at the end I'll talk through how you can feed into the consultation, but hopefully you'll start to get a flavour today of our framework and we'll have a chance to have a conversation. So Jonathan, I'd like to hand over to you. Jonathan is our Chief Medical Officer and also our Interim Director for Centre for Guidelines. Thank you.
Thank you, Claire, and good morning, everybody. Thank you for joining us both from within the UK and internationally this morning. My name is Jonathan Bendra. I'm the Chief Medical Officer at NICE and Interim Director of the Centre for Guidelines. I'm also a practicing emergency and pre-hospital physician in Bristol in the UK and Professor of Emergency Care at the University of the West of England. Keep me busy. We are going to be recording today's webinar so that there's a record of it that can be shared with others who aren't here today, and also so that you can share it with your children and grandchildren in the many years to come. What I want to do initially is start to talk about why we are changing our approach to prioritisation and topic selection. Then I'm going to talk through how we're going to change it and how we're going to proceed from here. We're not changing everything, but we are looking to ensure that things are considerably more coordinated and clearer and more transparent in the way that we approach topic selection in the future. So if you can move on to the next slide, please. Many of you will be aware that NICE is in the second year of a major transformation programme, which is really designed to ensure that we address the major challenges that exist in the health and care system today. NICE is 25 years old this year, and we're very proud of what NICE has achieved and its national and international reputation. And we're keen to maintain that reputation by adhering to our core values and not deviating from those values. So we will continue to ensure that we help practitioners and commissioners get the best care to pay people fast while we ensure value for the taxpayer. And that is still fundamental to what NICE does on a day-to-day basis. But of course, the NHS and the care system are under a constant change. There's a huge amount of pressure in the health and care system at the moment, which we're all aware of, that stretches across the entirety of the system. So primary, community, mental health, urgent, elective care, and social care are all under huge pressures, with a significant mismatch between demand and supply at present. We also recognise the importance of changes in the way that care decisions are made, and that NICE needs to play its part in supporting effective shared decision making and to continue to support innovation. It's absolutely critical for the future of health and care, and to address these challenges, that we embrace new technologies, new innovations, and new ways of working in order to deliver for the public of this country. And we have more data available to us than we've ever had before, which is a huge advantage. But we also need to ensure that we use that data in a constructive way, in a linked and intelligent way, alongside randomised trial and research evidence, and alongside patient preferences to make the best decisions to support health and care for individuals and for society as a whole. So NICE absolutely must respond to these pressures, but it must also ensure that we don't deviate from our core values. And so on the next slide is our kind of summary of our transformation vision. If you just go on to the next slide for me. So the three key areas that we're focusing on is ensuring that we're more relevant by focusing on what matters most to the health and care system, to patients, to carers, and to practitioners and commissioners of care. That our guidance is more timely and usable, so it's useful, it's usable, it's available in a format that works for our users. And we are really working, and Claire's appointment, Claire who introduced this session, is really working with her team to ensure that we demonstrate the impact that NICE guidance is having, and that that's a demonstrable impact on health and well-being across the system, and that we're implementing our guidance in a way that is genuinely useful. And we need to do all of that whilst preserving our core values of transparency, rigour and independence. And so that will stay the same, but how we do it will change. And today's presentation focuses on relevance. So my role within the organisation is to provide clinical leadership to topic selection to ensure that we do focus on what matters most, and so that we choose the right topics to provide the most benefit across the health and care system, taking into account all of those pressures and all of those challenges that I've described. So if you can move on to the next slide, please. I started in NICE a little over a year ago, and when we looked at our current processes, we identified that there were 6 different routes, committees and areas where topic selection decisions were being made within NICE. And clearly, when an organisation has multiple routes for deciding its priorities, there's a high risk of inefficiency, repetition, duplication, and also a lack of coordination. And so we want to replace that with a single prioritisation board that takes a central and integrated approach to prioritisation, that takes an overview of the entirety of the NICE guidance products that we have available to ensure that those outputs are coordinated, and that in effect our guidance is as integrated and as relevant to the system as it can be. And so by running a single board process with a single committee structure and a single team that will be taking an overview of all of our prioritisation decisions and coordinating the way that that translates into guidance, we're optimistic that this will lead to a greater degree of relevance, but it will also lead to a greater degree of coordination in our outputs so that they're as useful as possible for end users. Next slide, please. So there are 3 parts to this, 3 prongs to the work. The first is an integrated prioritisation board, and that board will subsume all of those 6 different groups and committees' activities. It'll work to a common prioritisation framework and a common set of processes and methods, which we are in the final stages of drafting now, and which we will share for consultation at the beginning of March. The framework that we'll be using to prioritise topics will be published, but it will be applied consistently in order to make our decisions as consistent and transparent as possible. We will publish those decisions, I'll come on to that. And we will also publish an annual forward view, so that every year at April-May time, NICE will publish an electronic document that summarises what we have done in the previous 12 months, identifies our key priorities for the coming 12 months, but also looks further ahead, working with our colleagues in horizon scanning to ensure that we signal to the system where we think NICE will focus its efforts over the coming years, and where we see emerging technologies and other developments in treatment where NICE will need to be involved in making guidance recommendations. Next slide, please. So the principles that we'll be working to as we prioritise are that we will be focused very much on the health and care system, and that's why we feel that prioritisation should be a clinically led function and falls under the jurisdiction of the Chief Medical Officer, working with a very wide range of our colleagues from across NICE. We think that this approach will ensure that we produce integrated guidance products. So having identified a relevant topic, we can then identify which different guidance products that NICE has that could be integrated to address that topic. Increasingly, we have a range of possible guidance products that we could use, so guidelines, technology appraisals, health technology appraisals, digital technology appraisals, and so forth, that can be integrated to form a more coherent package, rather than presenting different guidance products on the same topic. We want to work towards very much an integrated and coordinated approach to really meet system needs. NICE has a huge portfolio. It's got the largest publicly funded portfolio of guidance in the world, and we're very proud of that breadth and depth. But clearly, as the portfolio continues to grow, we also have to identify areas where guidance has become obsolete or is no longer required. And we also have to conserve and utilise NICE's own resources in the most efficient way possible. So the Prioritisation Board will make decisions around retiring guidance, and will also identify where other guidance is available that may be useful to stakeholders. NICE has a particular role to play in public health, social care and rare diseases. These are all key areas. We're often asked what's NICE's current approach on these areas. And so we wanted to set out some strategic principles as to how we will address these important topics within our prioritisation process. Again, we will be consulting on those principles. We'll come back to them in a short while. But the principle here is that we want to be as clear and transparent as possible. It's just not possible for NICE to prioritise everything. It's not possible for NICE to write guidance on all possible public health, social care and rare disease topics. But we do want to agree with the wider system and approach that we can apply consistently at board and that will guide our decision-making process in the future. As I've already alluded to, there are times when we recognise that there is already good guidance available to the system. To make the most efficient use of NICE resources, we won't duplicate existing guidance from other reputable guidance producing centres unless NICE can add specific additional value, for example, in cost effectiveness modelling or in other areas that are unique to NICE and to the UK. And it's absolutely critical that we continue to think carefully about the capacity of the system to implement guidance and ensure that our guidance is realistic and practical and can be effectively implemented by clinicians, practitioners and systems. Next slide, please. So in effect, we see the Prioritisation Board drawing together three kind of key areas, which is a unified approach to guidance across all NICE products and all NICE outputs, very clear input from system intelligence, by which I mean an understanding of what the system wants and needs, and the longer term position in relation to horizon scanning. And all of our guidance topics will be in scope, excepting that we retain some important statutory responsibilities, for example, in relation to technology appraisals, that won't change here as a result of the new Prioritisation Board. Next slide, please. We will be consulting shortly on our common prioritisation framework. We've looked locally, regionally and internationally and have identified that a two-stage approach to prioritisation will allow us to assess topics in the detail that is required, but in a way that's proportionate in terms of resource use. So step one is a slightly earlier filtering stage where we are looking specifically at whether NICE can add value in this topic, whether there is a clear health and care need that NICE guidance and methodologies can address, whether there is a suitable evidence base, and obviously the evidence base will vary depending on the topic, and whether that particular technology, in particular health technologies, are available or will become available in the UK. If a topic passes the screen at step one, then it will move to step two for a more detailed workup and will be presented to the Prioritisation Board for further consideration. And here we are looking at a wider range of considerations. So budget and system impact relate to the impact on the health and care budget and the health and care system of implementing guidance in this area, but also the potential benefits that are gained both in the short and longer term through population impact. Evidence quality will be a more detailed assessment of the available evidence and assurance that NICE has methodologies to address the topic itself. And there are two very important areas that we are explicitly introducing to our consideration and which form part of our discussion at every prioritisation board. which relate to the extent to which guidance is capable of addressing health inequalities, a critical part of the long-term determinants of health and care in the population, and the extent to which a particular piece of guidance will support sustainability in the health and care system, both in terms of service delivery, but also in terms of the NHS's carbon and green targets for the future, so that health and care continue to play their part in meeting our environmental commitments. And by balancing these factors out, and by discussing each topic with a detailed topic briefing that will be prepared by our topic intelligence and monitoring team, we hope to be able to reach fair, consistent and transparent decisions that we can then publish and stand behind, and which will guide our portfolio of work over the coming years. Next slide, please. Because we have multiple current processes in place, we have a range of different approaches where stakeholders have questions about our decisions or wish to query them. And so, as part of a single prioritisation board, we're introducing a single clarification process in order to allow us to correspond with key stakeholders and to ensure that where there are questions about the decisions that we've made or that further clarification is required, we can respond to that in a consistent way. As I've said, we will be publishing our process and our topic and routing decisions on our website. Stakeholders may request clarification by email, and we will ask them to complete a standard form seeking clarification, which we will then respond to within defined timeframes. We will be formally consulting on this as part of our consultation process next month. But the important thing here is that we want a standard approach that's clear and transparent as to how we will clarify questions around any concerns that anybody may have in relation to the decisions that we make. Next slide, please. So NICE has a particular role in relation to technology appraisals and highly specialised technologies that I know some people joining the webinar today will have a particular interest in. The first thing I want to emphasise is that our current processes for medicines will essentially continue unchanged because of the recent VPAG settlement. And NICE will effectively the prioritisation board will effectively take on some of the work that has previously been done by TSOP, the Topic Selection Oversight Panel, which includes routing decisions and the occasional technology appraisal where there may not be additional value in conducting a technology appraisal. But to all intents and purposes, the current processes and systems that are run through our TSOP will continue through the prioritisation board, and we're not planning to make any changes there. That means that the prioritisation board will make HST routing decisions also, and it also means that the clarification process that I've just described would apply to our HST routing decisions. Again, this will be considered further during the consultation next month. The HST criteria published in 2022, we're currently looking at those at the moment to decide whether they remain ideal in the way that they translate the aspirations of HST into practical decision making, and that review will continue. Should we decide that any changes may be helpful, then we would consult on those changes to HST criteria in a separate consultation later this year, but that has yet to be decided. And so at the moment, the current HST criteria remain, and HST routing decisions will be made through the prioritisation board, as I described. Next slide. Thank you. So, core to all this is transparency. I'm a huge believer in being as open and transparent as we can be. Clearly, it's impossible for us to meet all of our stakeholder needs, and I appreciate that people rightly will advocate for areas that they feel NICE should either be writing new guidance in or updating guidance in, and that of course is part of NICE's role. And we will continue to work closely with stakeholders, and we will do our best to make the best decisions that we can. But I'm sure that everybody recognises that we cannot possibly meet all requirements, and we cannot possibly produce guidance on all topics. And that's why prioritisation needs to be as clear, transparent and consistent as it can be. So we are about to enter a consultation process on our framework, on our criteria, our strategic principles for social care, public health and rare diseases. And we encourage you to respond to that consultation and give us your views, and we will make changes on the basis of the feedback received. Our prioritisation decisions will be published on our website. Where a topic is not prioritised, we will consider alternatives, so other ways that that particular need might be addressed. And if it is prioritised, we will consider what guidance products from the NICE stable might meet those needs. Although further workup will be done within NICE itself to determine the actual guidance that we will produce. And as I have described, we will adopt a single clarification process for all decisions of the board, and we will publish an annual full review to continue to communicate clearly with the system and to ensure that our future priorities and plans are clearly signalled and in the public domain. Next slide, please. We are absolutely committed to engaging patients and the public in our work, and that includes the prioritisation board. The prioritisation board will operate in accordance with NICE's principles in relation to independence. What that means in practice is that the board will only be composed of NICE employees, conforming to our usual standards in relation to declaration and management of interests, with the exception of specific lay representation, which we will draw from a wider patient and public and lay community, working with our colleagues who are engaged in patient and public engagement across NICE, to ensure that we really do ground the decisions of the board in the views of patients and public, in real life decision making, and in the experiences of people who use services, to ensure that we continue to listen to those experts by experience who have been so important in supporting NICE's work to date. And that will be a key part of the work that we do to ensure that patients and public are fully embedded in the process and are represented on the board and have a full and equal voice in the discussions and the decisions that we make. Our sponsor teams in the Department of Health and NHS England, we will keep them updated on the topics that are coming to the board, and they will, like any stakeholder, be able to feed into the board and give us opinions and views that we will consider, because we take the views of our stakeholders and our sponsor teams as a central part of the guidance to the work that we do. But as I've described, the board itself will be independent and will make decisions in an independent state, composed purely of NICE employees and patient and public representatives. But we will continue to work closely with our sponsor teams both before and after the board. Next slide, please. I've touched on our intention to consult also on some key strategic principles around public health, social care and rare diseases. NICE's remit extends across all of these areas. We recognise that the amount of guidance that is purely related to public health and social care has varied over time, and we want to try and establish a set of principles that would allow us to be consistent in our approach. We also recognise the risk that in a system that focuses on health and care system needs and potentially the number of individuals who can benefit from guidance, there is a risk that rare diseases will not be given sufficient priority. And so we wish to address that head on by developing a set of principles that will specifically set out how we're going to approach rare diseases to ensure that they are proportionately considered by NICE. And we look forward to consulting further on those. The key thing, I think, is that we have already engaged quite extensively with the public health, social care and rare diseases community. And so I'm optimistic that we've got to a reasonable set of principles, but we will be consulting formally on those from the 5th of March, and we look forward to further feedback. My view is that by having a set of published criteria and principles that the board can work to and that our stakeholders understand, we can take a more clear and consistent approach. So that's a summary of where we are. The next slide says any questions, so we can go there. We've left plenty of time for Q&A, and I know that people are submitting questions through our chat function, so thank you for that. We'll endeavour to answer as many of those as we can, and then we'll close with some further details of the consultation and how you can get involved.
Questions in, so keep them coming. What I'm going to do is group them into themes, if that's all right, because there's a lot that are coming in, a variation on a theme. But what I just thought I'd start with, Jonathan, is some more kind of clarifying questions. These are obviously people who are used to been working with NICE in the past and are trying to work out how will it be different. So kind of coming back to how this happens now, somebody was asking about topics being referred from NHS England, and just what they were kind of saying is, how does that kind of change going forward? Will that still happen? And for people who feel that a topic should be developed, how would they feed in?
Yeah, thank you. So, so our intention is to have a single point of access, so a single front door or letterbox, if you will, through which anybody can make any suggestion. So it's not in any way restricted, and so that will allow people to make suggestions for topics that we will then consider. And I anticipate, of course, we'll get multiple suggestions for the same topic, and so on and so forth. In certain circumstances, a topic will go straight to stage 2 for prioritisation, and those circumstances include an update to an existing guidance product, because we already have the product, so we don't need to run through the stage 2 process, and so we'll go straight to stage 2 for consideration. Similarly, formal referrals to us from the Department of Health or NHS England will go straight into a stage 2 prioritisation process. And as I've described, we will continue to work closely with our sponsor teams in DHSC and NHS England to ensure that they are aware of the topics that we are considering a prioritisation board, that they can feed in their views to the board for consideration, but the board continues to make independent decisions, and will update our sponsor teams on the results of the prioritisation board outputs just before they're published on our website. So and obviously we still have a statutory framework within which we will work. We will continue to work within that framework, particularly for technology appraisals, but also for any other the other legal instruments that exist to support NICE guidance. And we're discussing with the Department of Health at the moment how to ensure that that is retained. We're not planning any changes in legislation. We're not planning any major changes in that respect. But we do want to make this a more open process. Where a topic has not been prioritised, we will of course reconsider that topic again in due course. That would normally be where a situation has changed, so more evidence has arisen, or there's more additional information or data has become available, and we'd normally leave 6 months between considering a topic to give time for that kind of information to become available. That I think will give us a clear and consistent approach. As I say, the risk, of course, of having a very open process is that a lot of people will still suggest a lot of things, and we just won't be able to do them all. But on the other hand, I think it's important that people feel that they do have the opportunity to make suggestions, and to talk to us about their concerns and areas that they'd like us to focus on. As I say, for certain things, they will go direct to stage 2. For other things, we will consider them through our pre-selection and stage 1 processes, and we'll see how that goes. I hope that it doesn't become unmanageable from a NICE perspective, but I am slightly wary of the risk of obviously getting quite a lot of suggestions in the initial stages, and NICE has only got so much capacity and can only do so much guidance, unfortunately.
So kind of following on from that then, Jonathan, somebody's asked, you talked about NICE won't replicate guidance where other guidance is available. Can you, oh sorry, that's just kind of moved up in the questions. Can you just talk a little bit about some of the thinking there? Are we thinking that there'll be a process to accredit external guidance where there is already high quality guidance in that space?
Yep. So that's a different part of my portfolio is working with colleagues to look at how we work constructively with colleagues from other reputable guidance producing centres, both nationally and internationally. NICE historically has an accreditation program, which has been very successful in accrediting organisations who produce guidance. That program is still exists, but we're not currently taking new kind of accreditation activity. And I think what I'd like to do is review how we approach this, so that where there is good quality, evidence-based guidance available on a particular topic, there are a number of things that we can do with that guidance. So we have excellent relationships with pretty much all of the guidance producing centres nationally and internationally, and everybody's interested in collaboration and avoiding duplication. So that might range from simply kind of curating content and signposting to high quality guidance elsewhere, right the way through to effectively collaborating with other guidance producing centres in order to produce coordinated guidance. So a good example would be our updated asthma guidance that's about to be released, where we've worked very closely with BTS and SIGN to ensure that we each address key areas of asthma without overlapping or competing with each other. That's very efficient. There's also the opportunity to adapt reviews and systematic reviews, or to effectively take a guideline that may be written for a different country, and adapt that guideline in a way that allows it to be more successfully applied in the UK. NICE has a particular role in cost effectiveness, which many guidelines don't, or guidance products don't take into account, and so sometimes that's a big area. And obviously international guidance may express societal preferences or services that are not routinely available in the UK, but there's a kind of adaptation approach. So what we're looking at really is a spectrum that ranges across a range of possibilities. What I'm keen to do is to use NICE resources wisely and not in effect produce a guideline or other guidance product that's extremely similar to another highly reputable product, because I think that just causes confusion, and potentially isn't a good use of the taxpayer's resource when there are so many other topics which NICE could address.
No, that's all very clear. So quite a few people want to know a little bit more about the composition of the prioritisation board, Jonathan. So who's on that prioritisation board?
Yeah, so the terms of reference are in our consultation, including the composition of the board, although that is itself a variable situation, because I think it will evolve over time. Broadly, it's chaired by myself as the CMO. It has a strong representation from the clinical directorate, but it also effectively has strong representation from our guidance producing centres and the wider organisation. And all parts of NICE are represented on the board. And there are two things there. So one is the strategic decision making as to NICE's direction, informed by system intelligence and your own team, Claire, for example. But it's also about capacity within the system. So operationally, we need to be careful that we don't prioritise more work than we can actually deliver. I'm very keen to avoid creating a backlog where we've promised to do some guidance, but we don't have the capacity to do it in a timely way. Which I think is very frustrating for all parties, because NICE has said they'll do it and then there are delays, and then sometimes if you have a backlog, new stuff comes along that's considered to be a higher priority and things get pushed to the back of the queue, and it gets very, very frustrating for stakeholders. So it's a combination of strategic decision making based in system intelligence and system knowledge. And it's worth saying that the papers that will come, so the standard briefing that comes for each topic, takes a couple of months to work up. Our topic intelligence and monitoring team will spend a lot of time engaging with the system. So with system experts, clinical experts, patients and public, patient groups and advocacy groups, to really understand the topic from as broad a set of perspectives as possible. And so that briefing paper will be widely informed by the system, not by NICE. And it will really say, this is a description of the system problem. This is where the guidance would work and how it would add value. People can sometimes misunderstand where NICE is most successful. So NICE is very successful in standardising the way that clinicians and social care practitioners deal with, manage, interact with individuals. It's very, very good at kind of clinical guidance, saying, if you have a patient with this problem, do these things. NICE is a much more of a, and that includes, by the way, drug prescriptions, of course. So, whether drugs are indicated for particular patients in particular circumstances. NICE is weaker in kind of driving commissioning behaviour systems, and addressing inequalities that may exist in service provision. So I'm not saying we shouldn't do it, and there are some methodologies that are particularly problematic, and so we have to accept that NICE does certain things very well. It does cost effectiveness extremely well. That's where NICE is founded. That's where our reputation is based. It does other kinds of assessment and methodology less well. And there are some areas where, for example, evidence is very, very sparse, where the best approach is often expert consensus. And there's nothing wrong with expert consensus. And it's the right thing to do if there is no data or research evidence available. But I don't think that's an area that NICE excels in, and I would generally suggest that where something requires expert consensus, it may be best done by specialist societies, medical royal colleges, special interest groups who have knowledge in that area. NICE is very much, I think its strengths are in evidence synthesis, the incorporation of real world data, and in cost effectiveness analyses, and we should play to our strengths. And that will be a consideration in deciding what we should prioritise, because we need to add real value to the system with everything we do.
So 2 kind of theme questions, if that's all right. So first one is really about how can guidelines be more dynamic? What are the opportunities for working with medical specialty organisations, royal colleges? And then how does this kind of fit in the context of the health and care system in its current state? So how are you considering NHS or health and care capacity? And really, somebody was specifically asking, is there an aspiration through this approach to increase capacity and resource, or a real kind of concern that innovation will be held back potentially if we're kind of pushing in things that matter most? So the first question, Jonathan, was really about how can those guidelines be more dynamic based on what you've just said, what the knock-on effect of that is, and how do we consider how that lands in the system?
Yeah, okay. So the first thing to say is that we recognise that NICE has not always been the fastest thing in terms of responding. He said carefully. So we need to get quicker, and we need to respond more effectively to changes in the system, new evidence, and new practice, which includes innovation. And so there are a couple of ways that we're approaching that. The first is to really think about our processes and methods and to try and align and streamline those as much as is humanly possible so that we can go faster and we can deliver more quickly. There is, of course, always a trade-off between quality and speed, and NICE is never going to be an overnight organisation. And indeed, our stakeholders don't really want or expect us to update the guidance daily because it's impossible to keep up with it. It's infeasible for us to deliver it. So we've kind of fixed on a 3 to 6 month kind of time frame with the idea that NICE guidance should be updated in priority areas within 6 months of publication of practice changing evidence. And the way to do that is through a more modular approach. So rather than trying to update an entirety of a guideline, which takes a long time, what we are working to do at the moment is effectively update in a more modular way, piece by piece. So those of you watching sepsis, for example, at the moment we're updating sepsis in stages in order to ensure that our updates are more timely. Now that's working, except that when we update in a modular way, the guideline itself can start to become a slightly disjointed thing, because we update part of it and we realise other bits of the guideline need to be updated, and we have to come back to that. And so that there is a complex trade-off between kind of speed and coherency within the guideline. So it makes the guideline more accurate, but it potentially undermines its coherency because it no longer agrees with itself because we've updated it in a modular way. But the general mantra here is to find ways of writing short stories rather than very long novels, which I think will increase our speed. The other thing that's very important around, just from a guidelines perspective, but potentially more widely, is our creation of topic faculties and kind of some key kind of suites of work. So within guidelines, we're working around 4 suite areas, which are mental health, women's and reproductive health, cancer and cardiometabolic disease. And about a half to 2/3 of our guideline portfolio is likely to fit into those suites. There will always be a range of other things that don't immediately fit into those suites, and those suites will change and develop over time. But they will be driven by faculties which are broader than our guideline committees. So faculties will be drawn from a wider range of stakeholders, including things like medical law colleges, patient and public groups from industry, to give us a broader understanding of a topic and developments in that topic where innovation is occurring. And then from those faculties, appropriate individuals who are qualified to do so and work and who can act independently, fulfilling our usual criteria for conflicts of interest, will be co-opted into guideline committees to do the actual committee work. So the requirements to join a committee won't change, but the faculties themselves will be a larger organisation from which committees will be drawn. And those faculties will work across the whole of NICE, not just in guidelines, to support knowledge and decision making, and also identify and drive innovation through the system. So I think that will help us, but we need to continue to work carefully to ensure that we respond to system needs and requirements. Moving on to system needs and requirements, there is a real challenge, obviously, in the incapacity in the system, and NICE's role is to recommend excellence in health and care for patients. And of course, sometimes that is extremely difficult to deliver in a very challenged system. And we get a lot of feedback from stakeholders who ask us whether we have fully considered the implementation costs and the implications of our guidance products. And the answer is we do fully consider those, and we try very hard to produce support tools and other implementation activities to try and help systems to implement our guidance. But we do recognise that in a very challenged system, we need to be very cognizant of the costs of implementation, and also be clear about whether something is cost effective, cost neutral, or cost releasing into the health and care system. And I think over time, it's important that we continue to adhere to our core principles, but at the same time, we are very, very carefully thinking very carefully about the wider system requirements. And this is where prioritisation is critical. We need to prioritise the right topics that will drive excellence in health and care for the whole population, and which are achievable by the system and which will be welcomed by the system. And that's a balancing act that NICE will, I think, continue to work towards, and which myself as the Chief Medical Officer, working with Sam Roberts, our Chief Executive, these are areas that we talk about on a weekly basis, and how to get that right, so that we continue to preserve our core values and role in the system, but we continue to respond to the system challenges that we're all experiencing. And that I work in my emergency department every week, and I know exactly what those challenges are.
That kind of theme then, Jonathan, kind of a variety of different questions have come in around how will prevention healthcare strategies be included and prioritised? How do we consider the impact of health and care inequalities and health equity, and how we are making sure that the people and communities that potentially could be impacted even more profoundly if guidance is not prioritised and implemented in the most effective ways is considered. So more from that longer term health inequalities, prevention, actually how do we help the system to make sure that we're kind of thinking long term for people and communities?
Yeah, so I mean, prevention is part of NICE's role, and that's set out in our public health strategic principles. There's an increasing recognition, I think, in health and care at the moment that we need to create a healthier population in order to reduce future health and care demand. It's a tricky one because it takes a long time to realise that, but we need to invest now in order to make important gains in the future. And we're actively discussing with NHS England at the moment how we can further identify and prioritise key public health interventions to drive a healthier population, because that's one of the key areas for controlling budget, and expense in healthcare. Those of you who've read Chris Whitty's latest report on this, it's really very clear, the message there. And we can increase the number of years of healthy life expectancy for people. I mean, it's not total life expectancy, but it's the number of years in good health. And that has a massive impact on health and care services. So we need to start investing there now, and NICE is committed to doing that. We're also committed to examine and actively address healthcare inequalities, because there is a huge disparity in the kind of highest and lowest deciles in our population in terms of exactly that. So years of healthy life, and so that's why our framework specifically addresses health inequalities. So no topic will go to board where we will not discuss the potential impact on health inequalities that the guidance might achieve, and then that will be translated through the guidance production itself and implemented by NICE in a way that we would endeavour to support systems to implement guidance in a way that will reduce health inequalities. Now, this is a huge challenge, but that doesn't mean to say we shouldn't try it, and we should work hard to achieve it. And that, for me, goes hand in hand with sustainability. We need a sustainable health and care system that actively addresses health inequalities. So, my pledge to everybody on this call is that in the future, NICE's prioritisation decisions will explicitly consider health inequalities and sustainability. It's not going to be it's not, there's so much we have to do. It's not going to be the fix, but we have to do our bit to identify and to address and to start to surface this challenge, and to find ways to reduce health inequalities in order to improve the long-term health and well-being of our population. And we are, NICE's board and executive is committed to that task.
Completely agree. And we could have a whole session on this, but just kind of moving on then. Two more themes that I'm going to pull out. I'm just conscious of time. The first one is around rare diseases, and then the second is more kind of from a medicines lens. So rare diseases, you mentioned, Jonathan, but how will you potentially consider late stage disease? Will you think about prioritising late stage disease where there may only be limited options, but perhaps only for a few patients? You've already talked about you're kind of working through the thinking in terms of rare diseases, but I'm quite certain there'll be lots of people on this call thinking, gosh, how are you going to factor this in? Because it really, really is terribly important to them.
Of course. And so our principle around rare diseases we will consult on. Broadly, it's not feasible for NICE to create bespoke guidance products for every rare disease. There are 7,000 of them. And so it's clearly not, that's not possible. And so our role in relation to technology appraisals won't change. So medication for rare diseases will continue to be processed in the same way. There is a particular challenge, which you've alluded to, in late stage and kind of almost personalised medicines, where we're looking at modern technologies offers some amazing opportunities but for very, very small numbers of patients, potentially one individual. And I don't think we have reached a solution for that yet. But it's a challenge that we need to actively address over time. The best way, I think, of approaching rare diseases is to try and take a broad approach and to say, well, where are there commonalities that people with rare diseases experience? So while recent quality standard in relation to transition between children's and adult services has a high degree of relevance to people with rare diseases and has been well received by the rare disease community. And the reality is that if you group all those rare diseases together, you get a common disease. 3.5 million people will be affected by a rare disease at some point in their lifetime. And so we're committed to identifying those commonalities, those particular challenges, and the prioritisation board will be looking for ways to create and prioritise guidance that addresses those kind of clusters of symptoms and challenges that are experienced by people with rare diseases, whilst being honest that we're not going to produce a bespoke guideline for 7,000 rare diseases, because A, the evidence is often lacking, and B, we just don't have the resources to do it. But again, what I found speaking to colleagues from the rare disease community and so forth is that people are very realistic about this. Nobody expects NICE to write thousands of guidelines for rare diseases. But on the other hand, they rightly expect NICE to come up with a strategy and make sure that there is a proportionate allocation of NICE resources that is dedicated to addressing the problems that people with rare diseases face, and where, if we can do that through common challenges, it's going to give us the most efficient and effective way of reaching more people. In terms of say medicines, as I've seen some of the questions coming through.
Specific question. Oh, sorry, Jonathan. Was so you might be able to answer this really quickly. So somebody was saying, does it mean that NICE may no longer look at all new pharma products and license extensions like we currently do, or is this more about the approach that we're describing today, more about diagnostics and guidance?
Yeah, so just to emphasise, there will be no change in NICE's approach to pharma. So we will continue to produce technology appraisals for any new medicine or significant new licensing indication. There is the occasional exception where historically NICE hasn't always produced guidance, and the TSOP made those decisions, and the prioritisation board made those decisions. But to all intents and purposes, the legislative framework we work to won't change. You could for most of the work, you could cross out TSOP and write prioritisation board, and you'll get the same answers. So the scope of what we do in relation to drugs is not going to change. And much of what we're discussing is, as you say, related to other parts of the portfolio. One of the key differences, though, is that because the prioritisation board will see the medicines, the prioritisation board won't be able to say, no, we're not going to do that, because the reality, if it meets our legal requirements to produce a technology appraisal, we'll produce one. The prioritisation board's got nothing to say about that except for fine. That's what we do. But what it might say is that's very interesting. How do we update our other guidance products to fit around it? So a very good example would be the moment. So there are a number of drugs coming to the market which are being licensed for the treatment of obesity, and so that leads us to say, well, this is a really important development. How would we update and unify our other guidance products to support that, so that people don't just get a technology appraisal, but potentially they get a supporting suite of guidance that sits around that technology appraisal. And NICE is committed to integrating our technology appraisals, our medtechs, into guidelines in a way that is more user-friendly. So that, because at the moment, because the prioritisation process is slightly disjointed, you can get different products produced quite close together in time, but which aren't very well integrated for the end user. And so this will drive a process where, say, a new class of drugs, for example, could be supported by new medical technology guidance, new guidelines, so that the health and care community can implement that class of drugs in a more effective way. And so there are some advantages from a pharma perspective, because we will be taking a broader view, and also we're looking to specifically identify and drive innovation. So if there are innovative technologies, so in terms of health technology, digital technologies, we're doing a lot of work at the moment in early value assessments of digital technologies that I think is being well received by the system, not least because it can help address kind of demand and empower patients to self-manage under some circumstances with support from clinicians as appropriate. These kinds of things can be more integrated, and we will be looking on the prioritisation board to actually to specifically prioritise areas where we think there are significant system gains to be made.
Brilliant. That was my next question. What did you mean by integration? So just a couple of kind of practical questions then. What happens to deprioritised items? Are they held? What's kind of some of the thinking? And then a very specific question on when's the next annual forward view likely to be published?
So I think there are two. Deprioritised might mean that we decide to retire guidance. So guidance. So for example, the biggest win for us is to retire guidance that is no longer required or used. But also there's also a role for NICE to ensure that we don't recommend technologies or other interventions that are no longer effective or not considered effective by the system. And I'm keen to ensure that we use the prioritisation board as a transparent way of keeping an eye on the portfolio. The problem is the portfolio gets bigger and we got more updates to do. Eventually you just do updates and there's no capacity left for any new guidance. So we are going to have to be fairly thoughtful but also decisive about actually saying we're going to retire this product and not update it because it's no longer current, or it's not of the value, or it's less value than other work that we could do with the same resources. In terms of topics that we say no to, in effect, where a suggestion is made and we consider it as stage 1 or stage 2 and we don't prioritise it, we won't routinely return to those topics unless they're re-presented to us after a suitable time and with evidence that there has been change. So, clearly it's not in anybody's interest for us to look at the same topic repeatedly, because if the board is working correctly, it will always produce the same decision if given the same inputs. But if the inputs change, so if more new evidence comes to light, new papers are published, then clearly the board should review any topic that it may have said no to previously, but it may now say yes to because those circumstances have indeed changed. The first full review, I think, will be published in May, which is when we intend to establish the first full board. We've been running the board in a shadow format, which doesn't mean we meet in a darkened room. It means that we're practicing for a board and we're trying out our processes and kind of working through an interim set of kind of ideas. We've kind of done prioritisation of things we've already prioritised previously, see whether we get the same results. And we're starting to move towards more of a kind of consideration about how the framework will work in practice. From May, the board will become fully functional, we'll make binding decisions, and we'll publish our first full review. That will principally be a look forward rather than a look backwards.
Lovely, thank you, Jonathan. And just before we wrap up, there's been a number of questions. Obviously, this is my chance to grill you today, Jonathan, but lots of questions in there about implementation, which we haven't had a chance to kind of talk about today, but people are absolutely right that, we can produce the most relevant guidance, but unless it's visible to the system and to our health and care professionals and our people and communities to be able to see what we're recommending, then all of this work starts to be undermined. So what you will kind of see over the next 12 months and beyond is hopefully a really kind of refreshed approach in partnership with both the voluntary and community sector, but equally with the health and care system, so that we are making very clear what's coming out, and really helping people understand the tools and partners that are available to make sure that we are focusing on implementation. So I am going to come now to our final slide, if that's all right. And thank you, Jonathan, for that really comprehensive summary of how do we get involved and have a say about our plans. So if you just want to pop up the last slide for me. So consultation on this topic, so our integrated topic prioritisation manual, takes place and starts on the 5th of March. So it runs pretty much for a month. The consultation will be live on the NICE website during this period. So we'll be absolutely kind of pushing this through our social media channels and through our for more information. And I'm quite certain that we will let people know, all the people who've registered, that this is open. So lots of chance for you to have your say. I'm just really conscious that we had so many questions in, and I have hopefully kind of gone through themes today. But thank you so much for everybody who has joined us today, has put in some really, really helpful clarifying questions and the burning questions actually that we can only work through with our stakeholders as we move into that full prioritisation board and approach. And we need you to come with us on that journey. So thank you, Jonathan, for taking us through that today. Thank you, everybody. I think we had about 800 people join us today. So we are incredibly grateful that you've given up an hour of your time to hear how NICE is transforming to make sure that we are prioritising and focusing on what matters most, and enjoy the rest of today. Thank you very much.